So I thought moving forward it would be a good idea to go back and kind of review where we started in the second section, because everything's going to be very, very intertwined. And where we started, of course, in this section was water handling. And so we talked about the importance of water handling in the body, of course, because we're mostly made of water. And we talked about water handling in terms of sodium and chloride. And a few of the things that we talked about, I'm not going to go into a lot of detail, were things such as osmolar receptors. And of course, osmolar receptors, we'll just leave off the receptors, they sense increases in osmolality, and a big one is that increase especially in sodium, but there's other things as well. And of course, this results in a release of ADH, which goes to the distal tubules, and we then retain free water. So that's sodium-free water. We also talked about things such as the renin-angiotensin-aldosterone system, which senses decreases in blood volume and in blood pressure from that juxtaglomerulus apparatus in the kidney. And then aldosterone, of course, goes to our distal tubule, similar to ADH, although a different part where ADH mostly works in the collecting duct. The distal convoluted tubule is where aldosterone works. And so what does that do? That tells us, or it tells the body to retain sodium and chloride, so to retain water. And of course you excrete out potassium with aldosterone. Other things, of course, we talked about was actual renal function. So of course you need the kidneys to work in order for you to be able to retain water. And that's not just in that distal tubule, and we'll kind of review those concepts a little bit as well. So let's actually move on to kind of reviewing the kidney a little bit, because again, this next part where we're going to go into is actually going to be talking about why sometimes we concentrate or we don't concentrate, and it's unrelated to renal disease. So let's actually draw kind of our functional unit of our kidney, which is our glomerulus and our tubules. So of course, again, that first part is our glomerulus, and the important thing about the glomerulus is all about glomerular filtration, and we talk about decreased GFR a lot when we talk about dehydration and renal failure. And of course, the function of the glomerulus is to filter blood. So of course, it makes, again, a cell and albumin, and as well as larger protein-free filtrate. And the reason it does that is because those waste products are rather large, so we have to lose a lot of small things actually going through the glomerulus to get there. And so GFR, right, so that was that whole glomerular filtration, is going to be dependent on how many nephrons you have, again, so how many actual functional nephrons you have to filter the blood, and how much blood is actually getting to the kidney. So when we talk about renal azotemia versus pre-renal azotemia, how much blood gets to the kidneys is the pre-renal, and the renal is how well the kidneys are working. Post-renal is a little bit different. And again, that's that functional nephron when we talk about numbers of glomeruli. Next, we're actually going to talk about the tubules, and then again, just remind you kind of what happens to the tubules. So of course, a big, big area where a lot of water is reabsorbed, more than 60% of water is reabsorbed along with sodium and chloride, is this proximal convoluted tubule. And so if you have kidney injury, especially acute kidney injury, and certainly chronic kidney disease, you can have a lot of loss of water, and as well as electrolytes and things. And of course, that would be a renal cause of an inability to concentrate your urine. Your loop of Henle, of course, in your medulla, so if that's our dividing line, tons and tons of sodium and chloride are reabsorbed within your ascending loop so that water can be passively reabsorbed in your descending loop. And of course, this makes your medullary interstitium really salty. So when we talk about medullary washout, what we're talking about is that this salty area that facilitates that whole water reabsorption is not so salty. And so when we talk about, again, medullary washout, that's going to be the area that we're talking about. And of course, loop of Henle disease can be actual renal disease. So you can have disease within this medullary interstitium, so some sort of interstitial fibrosis, what we can see in chronic renal failure, but you can also get medullary washout, such as from diuresis or animals that are polydipsic, even animals with hypoadrenocorticism, and they can't reabsorb sodium for a variety of reasons, and so this is less salty. They don't actually have renal disease, but they can't concentrate as well. So of course that part I just added was our distal convoluted tubule, not so convoluted, and of course that's where aldosterone works, and I already kind of reminded you what aldosterone does. So of course renal disease, meaning your tubules are very affected by something going on, maybe you have ethylene glycol or vitamin D intoxication where everything gets mineralized, that could affect any area of it. But if you have a lack of aldosterone, you're going to lose a lot of water as well, and then you won't concentrate. And of course this last part is your collecting ducts, and so there's lots of collecting ducts, and of course this is where our ADH works. And we've talked before about ADH, and that you can get nephrogenic diabetes insipidus or even central diabetes insipidus related to either a lack of production of ADH or a lack of response to ADH, and that could be causing a kind of non-renal reason for a lack of concentrating. All right, so again, the glomerulus filters blood, right? So here's our glomerular wall. And here's our very messy capillary. And so what goes through here is everything except albumin stays in the blood and cells stay in the blood. And Dr. Walsh taught you all about glomerular disease where you actually have a loss of albumin through there. But let's talk about glomerular filtration for a second again. And the goal is to get rid of waste products. And these waste products, they come out in the urine. And the big waste products are things like creatinine, even BUN, even some urea is considered a waste product, although we do reabsorb some, hydrogen ion. Potassium, again, I've told you this a few times, fractional excretion is 20%, whereas something like sodium is 1%, so it's technically a waste product. Phosphorus, even ammonium, various other things are considered waste products. And so we use BUN and creatinine as our measures of glomerular filtration. Even phosphorus increases, and that's because when you either have less blood flowing across your glomerulus from dehydration or you have less functioning nephrons, these are not going to be filtered, so they're going to increase in the body. So, and of course that's different than our tubules, and of course our tubular function, again, is to reabsorb all those important things that you allowed to go through. So all of those electrolytes, water, amino acids, glucose, all of those things that you don't want to lose, and you want to concentrate your urine. So you reabsorb things, you concentrate your urine by reabsorbing water, and you do secrete some things. And so those are all, when we talk about our various renal functions, I'm going to kind of review azotemia quickly as well. But that's what we're talking about, tubular function versus glomerular function. So glomerular specific disease, the main one that we've talked about is that protein-losing nephropathy, which can be due to amyloidosis or glomerulonephritis, and you need a biopsy to differentiate it, and that is where then albumin gets through. So that's like a specific glomerular disease where now you get a protein going through that shouldn't be, and that's albumin. Tubular disease can be due to renal disease specifically, acute kidney injury causing actual death of these tubular epithelial cells, which then wind up becoming casts in our urine. It can be something like that interstitial nephritis causing kind of secondary damage. There's a variety of things that can then cause that. And so we may look for protein loss within our urine to tell us there's glomerular disease, although we can say it was some tubular disease. Things that tell us that there's tubular disease or tubular injury might be things like cellular, granular, and waxy casts. You might see some glucose in the urine without high glucose in the plasma. You might get a loss of bicarbonate, maybe some glomerular loss. And we'll talk some about the differences in acid-base type things as well. So, of course, azotemia is an increase in urea and or creatinine. And so in monogastrics, or small animals, we use urea and creatinine, although creatinine is thought to be more sensitive. You'll hear later on about something called, not in our class, SDMA, which is also a good measure of glomerular function and glomerular filtration. And so these are all measures of glomerular filtration. Now, a few things to note: that creatinine can be not increased in animals with really poor muscle mass. So in that case, you might just see an increase in urea. And in large animals, you might just see an increase in creatinine, or more so an increase in creatinine over urea, because they can use urea, the bacteria in their rumen and cecum in in cattle and horses, respectively, can use urea as a kind of energy product. So, of course, Dr. Walsh told you about azotemia and how we characterize it as pre-renal and post. And so you're still going to start by looking, of course, at your urine-specific gravity. And we're going to practice this a lot. So we're going to start by looking at our urine-specific gravity. And, of course, remembering that pre-renal causes, the big pre-renal causes are going to be dehydration. And this can cause an increase in urea or creatinine. It could do both. Again, in old animals, it might be urea more so than creatinine. In very dehydrated animals, it might be more urea than creatinine, because as you have a decrease in tubular flow, more urea tends to be reabsorbed. In large animals, it might be more creatinine than urea, because they can use urea. Now, the other cause would be GI bleeding. And of course, that's only going to increase your urea. And that's because there's that increased protein. So that's technically a pre-renal cause, but that's only going to be urea. And of course, in these, we're going to look for that urine-specific gravity greater than that 1025, 1030, and 1035 in large animals, dogs, and cats, respectively. So can you have of course you can have a pre-renal component of pre-renal azotemia component in animals that have other causes of azotemia. So you're going to look for all those things that we've looked at before to support dehydration. You're going to check the history. You're going to look and see, is the hematocrit elevated, is albumin elevated, or sodium and chloride increased. And if any of those are present, you automatically have a pre-renal component to your azotemia, regardless of what your urine-specific gravity is. So there's something concurrent happening. So, of course, renal azotemia can be due to acute kidney injury, which some people refer to as acute renal failure, although not all injury results in failure, or chronic kidney disease. And chronic kidney disease, some people also refer to chronic renal failure. Not at Penn, of course, but in general. And so we've gone over this a little bit, and we're going to go over more, but things that might support an acute kidney injury: clinical signs, physical exam findings, possibly pain. There might not usually be an anemia because it's a quick onset. You're going to check the history, maybe drugs were given recently, maybe there was an anesthetic event, some sort of hypovolemic event. It tends to have a relatively shorter course, so it's not a long, kind of drawn out affair. In general, I'm just going to kind of give you some general rules. Usually the calcium is going to be normal. I'm going to make some very overgeneralizations for you for a second. So we're going to see usually a normal calcium, not in the horse though, an increase in phosphorus from decreased GFR. We're going to often see an increased potassium, especially if you're not making urine, so if you're anuric or oliguric, but you might have a normal potassium. You can see glucose in the urine, so glucosuria, especially if there's proximal tubular injury. I can't write glucose, sorry. You might see casts. Casts are a great one, so cellular, granular, or waxy casts, so those could do it. You might see bicarbonate loss. Of course, you're going to expect a low urine-specific gravity. You might see an active sediment, so there might be some evidence of inflammation or even hemorrhage, although not always. The only type of crystal that's really specific are calcium oxalate monohydrates. They look like picket fences. That's a terrible picket fence, or a stake that you'd kill a vampire. I always remember this, the picket fence, that if your idea of death is suburbia, then picket fence will kill you. So, and that's calcium oxalate monohydrate, and we see that with ethylene glycol. We'll talk more about that. And you can see sometimes some proteinuria. So chronic kidney disease support tends to have a longer course. Maybe the animal's been long-term anorexic, weight loss, maybe they have some picky eating. The sediment tends to be very boring. They may have proteinuria though. A lot of times, although not horses, they tend to have a low calcium, and we'll talk about why that happens. They often are anemic, either from anemia of chronic disease or due to a lack of EPO. They, again, have a high phosphorus, and they often have a low potassium because they're polyuric. The next lecture, we're actually going to talk about kind of with azotemia and it being renal. So you have your renal causes and then your non-renal, and that'll be that next lecture. So I'm not going to talk about that now. Those non-renal causes of, those non-renal disease causes of renal azotemia. So post-renal, of course, the post-renal are really diagnosed by not just having blood work. You're going to need more information. And so whereas renal had our decreased urine-specific gravity, all those magic numbers, 1025, 1030, and 1025, post-renal can have any urine-specific gravity. So urine-specific gravity doesn't help. But the big things for post-renal is urinary obstruction and uroabdomen. And let's see, there we go. And the big one in both of these is we tend to see an increase in potassium. And you're going to need some more information, potentially. Often it tends to be a relatively acute onset. You can't live very long with the urinary obstruction or uroabdomen. You have to get the urine out. And we'll talk in the lecture after this next one, we'll talk about high potassium. Often you'll have a normal PCV, again, a high phosphorus from decreased GFR. The big ones for an obstruction is there's certain crystals that might tell you, and I'll tell you about those in a little bit. The animal might have a history of straining, there might be bloody urine, and of course uroabdomen, you're going to expect a decreased sodium and chloride. In the last little bit of review, I'm just going to mention proteinuria, because I know that, so although for azotemia we use pre-renal and post-azotemia, we do the same for proteinuria, but it's completely different. So pre-renal proteinuria, that is not how you spell pre-renal. Let's see, pre-renal proteinuria is not pre-renal azotemia. So they're different. And this is also called overflow proteinuria. So this, of course, means that there's teeny tiny proteins, and the ones we're really talking about are hemoglobin and myoglobin. So you're going to look for animals with intravascular hemolysis. And for myoglobin, you're going to look for animals with muscle injury, and we look for really high, something called a CK, which we'll talk about that later. So this is overflow proteinuria, very small proteins that are circulating in the blood spill over the glomerulus, and we see that in the urine. And of course, renal proteinuria can be glomerular. So there's glomerular, or they can be tubular. And the glomerular ones are where we get a lot of loss of protein, and these are our protein-losing nephropathies, especially where we become hypoalbuminemic. And so this can be amyloidosis or glomerulonephritis. There's many causes of glomerulonephritis, and even some of amyloidosis. They require a biopsy. You may or may not see azotemia, and that's true in the pre-renal as well. So renal proteinuria means that you have either glomerular disease, tubular disease, or both. They may or may not be azotemic. And post-renal proteinuria means essentially everything after your renal pelvis. And so a lot of times we see this with urinary tract infection and hemorrhage. And the most common, I would say, is bladder. Having difficulty writing today. So urinary tract hemorrhage, urinary tract inflammation, neoplasia, etc. So that's kind of the different. And the next thing we're going to go on, and we're going to work on those non-renal causes.